So, welcome to the Roche Integrated Symposium. My name is Beth Marlowe. I'm the Director of Medical Affairs for Microbiology. I'm going to be co-chairing this session with my colleague Rodney Arsenis. He's the Director of Clinical Sciences for Microbiology at Roche Diagnostics. The title of our symposium today is Syphilis, Chlamydia, Gonorrhea, Oh My, Diagnostic Advances, Hurdles, and Considerations. For our colleagues who are not from the United States, I'll just give you a little context in terms of the title. This is a play off of a saying from The Wizard of Oz, when Dorothy and the Tin Man and the lion are walking through the dark forest, and they get nervous because they hear noises of animals in the dark forest, and it's lions and tigers and bears, oh my. And if we think about the epidemic that we see around STIs and the increasing rise in syphilis and resistant gonorrhea, that was sort of the play on our title today. And we have three great speakers that are going to talk about these topics. Our first speaker is Dr. Marco Cucini. He is currently the chief for the Center of Sexually Transmitted Diseases at the University of Milan, where he also teaches at the School of Dermatology and Venereology, as well as the School of Urology. His research interests focus on STIs and the diagnosis of syphilis, as well as HIV. He is on the executive committee for the International Union Against Sexually Transmitted Infections and participates on several other STI organizations. Dr. Cucini is well recognized in the field of STIs and syphilis and has authored around 150 publications. Please join me in welcoming Dr. Marco Cucini. This is the pointer, and this forward and backwards. Okay.
Thank you very much, Beth. Good morning or good afternoon, everybody. I don't know what is the usage in Brazil for this time of the day. I'm waiting for my presentation to appear on. My talk will be about the current trends in syphilis diagnosis. I hope it will come in a minute. Time is still running, so. Yeah. But this is forward, and the other one was backwards. So let's go. You know that syphilis is a very fascinating disease to me and also to Sir William Osler, that is much more important than I am, of course. And he said, he who knows syphilis knows medicine. This is not completely true, but I think that who knows syphilis should know dermatology, immunology, infectious disease, and many other specialties. What is the state of the art of syphilis diagnosis in 2017? Treponema pallidum is sequenced and is not cultivable and is still highly sensitive, luckily, to penicillin G. Late syphilis is rare in Europe, but we have high prevalences of early syphilis, especially in MSMs in Europe. Molecular diagnostic testing are replacing dark field microscopy in the diagnosis of primary syphilis, and new automated treponemal tests are replacing TPHA and TPPA and mostly FTA in the diagnosis in the serologic diagnosis of syphilis. We have new guidelines, both from the America and from Europe. Well, clinical diagnosis of syphilis may be difficult for many of us. because syphilis is the great imitator. We heard early this morning a very interesting case from the United States. And with the renaissance of syphilis, we have observed many clinical patterns that were very unusual for us. Maybe that would have not been so unusual for Jean-Alfred Fournier, that was used to see syphilis in the late 19th century in Paris, Hôpital Saint-Louis. And these are some unusual cases. This is a primary chancre of the tonsil. This is a case distribution of two primary chancres. This is a sclerotic chancre of the penis, always primary syphilis. And not to forget female, this is a large primary chancre and some unusual localization. This is a primary chancre of the finger. And going a little bit towards, this is a primary chancre of the wrist in an MSM. If we move, this thing is, okay. Looking at secondary syphilis, this is a secondary lesions with mucous involvement in a HIV positive man. This is a strange case of condyloma thalatta, and again a localization of secondary syphilis with this annular pattern on the penis, angular cheilitis that is quite usual during secondary syphilis, as is usual syphilitic alopecia as a sign of secondary syphilis, with this step in the snow distribution, as we say in Italy. I move. Okay, this again late secondary syphilis with a large plaque, and this is, as you see, a very unusual presentation plaque, and you see that we reached the diagnosis just after a punch biopsy that is there. This is again secondary syphilis, and we were really surprised to find positive PCR for TP in this particular case. And this, again, the reverse omnibus sign, this is the eyebrow alopecia, well described by French authors, Fournier again, in the past. You know why the name is omnibus sign, because French syphilologists can recognize patients with syphilis just looking at them when they were on the omnibus. We have to keep in mind that eye is almost frequently involved in syphilis, and so this is a recommendation by the European guideline that any patient with unexplained sudden visual loss should be screened by syphilis. And this is a story we had in our clinic, no history of previous STI, HIV negative, married since 12 years, no history, or he denied any recent sexual contacts other than his wife, and wife was negative for syphilis serology. He has a syphilitic eye, and of course he had positive test for syphilis, and he was treated, of course, for syphilis. What are the points of discussion for the diagnosis of syphilis today? Diagnosis of primary, diagnosis of latent, screening for syphilis, and what test to use. Direct diagnosis started early in the last century with microscopic identification of Treponema pallidum. Then we had the rabbit infectivity test that is still the gold standard for the demonstration of Treponema pallidum. And then we have the Treponema pallidum genomic map late in last century by Fraser. And of course, we have to mention PCR. This is an image of Treponema pallidum on a dark field microscopy that we almost every day perform in our clinic, and I am fond of dark field microscopy. And this is our lab with our dark field microscopy. Sensitivity of dark field microscopy is with 10 to 5 organisms per ml. So the limits of dark field microscopy is that you must be experienced to find the spirochetes in the dark field microscopy. And this is not good, there's not enough specificity for extragenital chancres. Moving to PCR, these are slides that that my good friend Michel Genier from Hôpital Saint-Louis gave me. PCR was developed since the 90s, as we said. There is a sensitivity, there are some doubts about sensitivity because there are not so many paper comparing with the gold standard that is rabbit infectivity test. Few confirmation with other PCR study, and this is one of the first PCR we did. I think it's 1995 or something like that in our lab. Some of the study that I mentioned with sensitivity ranging from 91% versus 83% for dark field microscopy. This one is 82% sensitivity, and this in genital ulcer is 80% sensitivity. There is a recent meta-analysis published in 2013 by Gaillet-Géron that analyzes 46 studies, 30 dealing with primary syphilis, and the pooled sensitivity for ulcer was 78.4%, and specificity was 96.6%, looking at which kind of PCR, nested PCR or regular PCR, seems to be more sensitive than multiplex or real-time PCR in almost all the studies. So how to find Treponema pallidum mucocutaneous lesions? Dark field microscopy is good for genital lesion, but you need skilled staff. You have an immediate result. You can make a diagnosis just in 5 minutes. You have to consider sample lability. It's, of course, cheap if you have a microscope. What about PCR? PCR is much more sensitive and of course, but it's good also for extragenital lesion. It's not operator dependent. You need some time for result, and we just heard about from Angelica that time for results is a key issue in the field of sexually transmitted infection, but you can ship sample. It's expensive. You need a lab, but you can do together with other, the research for other pathogens. So direct diagnosis is indicated, of course, in primary syphilis, in extragenital primary syphilis, in reinfection, and in congenital syphilis. Direct diagnosis is not important in secondary and late syphilis, since we have, again, serology. And sometimes direct diagnosis should be achieved by histologic demonstration of TP, as I showed before in the case of the plaque. Serology is the basis of the diagnosis of syphilis. Serological tests have satisfactory positive predictive and negative predictive value, and serology can be done in 2-3 days, and is very cheap also, less than 2-3 days. And with 3 serological tests, you can achieve the maximum information almost in all cases. There are point-of-care tests, and we will see them a little bit further on. This is again from Michel, looking at the use of serology in primary syphilis with this kind of sensitivity, TPHA 83%, and VDRL, or a non-treponemal test, 67%. So this is not completely satisfactory, but we know that there is a window period during primary syphilis. I want to comment on this because you know that no test can differentiate syphilis from other treponematosis such as Yos, Pinta, and endemic syphilis, of course. And so you have to keep in mind this, especially when you treat patients coming from endemic areas for this kind of treponematosis. These are taken from the European guideline, and we recommend as a primary screening for syphilis a treponemal antigen test, and the RPR VDRL, the non-treponemal test, are not recommended as a primary screening test. This is not usual if you go to the States, for instance, where, again, traditional algorithm is still used, and traditional algorithms start with a non-treponemal test and then goes to a treponemal test just to confirm reactivity of a treponemal test. The reverse algorithm that we use is, of course, we use first a treponemal test, and then we use a non-treponemal test, not to confirm, but just to have an idea of the state of the activity of the disease. So confirmatory test, we can use another treponemal test to confirm, and we do not recommend, as in the European guideline, the FTA ABS, we do not recommend it no more. So if we go to the reverse algorithm, you can see that with a history of unknown syphilis, if the screening test is negative, no syphilis, and it's finished, with unknown syphilis, then you can have a positive treponemal test and RPR, and you have to check for active syphilis. In this case, syphilis could be probably with a second treponemal test negative, could be a false positive or a very old not active syphilis. And in this case, with unknown history of syphilis and 2 treponemal tests positive and 1 non-treponemal test negative, and the non-treponemal test negative, you have to check for history and clinical evaluation. Non-history of syphilis, of course, treponemal tests are not useful. They are almost always positive. You have to check with a non-treponemal test to look for activity of the infection. What are the advantages of one or the other algorithm? The traditional algorithms detects only active infection, but has a high rate of biological false positive and can miss primary and treated infection. The reverse algorithms detects early primary and treated infection, detects early primary and almost increased number of cases of early primary syphilis, and is, of course, very, very specific. It depends what test you use. Some test detects early syphilis earlier than others. The test for check the activity of the disease are non-treponemal tests, and so are the tests for monitoring the effectiveness of treatment, again, non-treponemal test. False negative tests can occur in non-treponemal tests, and you have always to remember the prozone phenomenon that is observed especially in secondary syphilis, with high titer of antibodies. Neurosyphilis is a difficult diagnosis. You have always to keep in mind the clinical picture, and lumbar puncture for the examination of CSF is indicated in when a patient has neurologic symptoms suggesting neurosyphilis, or ocular or auricular symptoms, and can be also indicated when HIV positive patient with an RPR titer higher than 32. But this is a point that could be discussed maybe. Let's come to point of care test. They have a use in not only in poorly developed countries. One is FDA approved. There are several kits available. They can detect both IgG, IgM, or IgA. Few minutes for the answer, and this is a very important advantage. This, of course, is an example with a positive reaction and a negative result. They demonstrated in several studies good specificity and sensitivity. There is maybe some difference in using whole blood or venous sample, and it seems in some studies that whole blood is less sensitive than serum sample. This is the specificity and the sensitivity of some pocket test that was tested by the WHO several years ago, so you see the numbers are satisfactory. And let me conclude with two difficult points. What is the adequate response after the treatment of early syphilis? In the guideline, there is said that a fourfold titer decline of a non-treponemal test at 6 months is an adequate response after treatment, and this is completely true. Russians are a little bit more strict, and they want, they say that an inadequate response is a stable positive viral RPR test or a fourfold decline reached after 1 year. If you look at this criteria, almost 15% and maybe of HIV negative and maybe a higher percentage of HIV positive do not meet this criterion. And this is a serological failure. Clinical failure, luckily, is far more uncommon. If you look at late syphilis, the adequate response is much more difficult to evaluate. A practical approach is that if you have an initial titer higher than 32, any decrease is good. If you have an RPR titer less than 122, it's just you can be happy with no increase after 1 year treatment. So I have finished. Just the summary, just to summarize, direct methods are the best methods for the diagnosis of primary syphilis. Serology is still the mainstay for syphilis diagnosis. Reverse algorithm has some advantages. And POC tests have good performances, but not a substitute for centralized testing. Thank you for your attention.
And we're going to hold all the questions until all the speakers have had a chance to give their talks. Thank you, Dr. Custini. That was a great talk. Our next speaker is Dr. Ricardo Diaz. He's an adjunct professor of the discipline of infectology at the Escuela Paulista de Medicina at the Federal University in São Paulo. As the director of the Laboratory of Retrovirology, he conducts basic and clinical research in molecular virology. He has published more than 100 scientific articles. Dr. Diaz also serves as an external consultant for the National STD/AIDS Program, is a member of the Consensus for the Antiretroviral Treatment for Adults and Adolescents of the Brazilian Ministry of Health, and serves on the Governing Council for the International AIDS Society. Please welcome Dr. Ricardo Diaz.
Thank you. Good afternoon, and thank you for the opportunity. Other way. Okay, that's it. So my goal here is to show you the interplay between HIV and HIV-infected people and STIs. So those are the conflict of interest. This is something that's in our time, the current challenges for HIV infection. So we need, of course, to talk about prevention. We need to treat early the patients. If we do have the resource, we need to decrease the residual inflammation. I will show you why. And also there are some research for the cure of the chronic HIV-infected patients. So this is the outline of my talk. I'm going to show you that HIV is an inflammatory disease and show the interplay between both HIV and STIs and how it works in the context of HIV prevention, and I will talk a little bit about microbiome. So this is an old extemporaneous, although right, definition of the HIV infection. It's an infection that causes the decrease in the cellular immunity, leading to a risk of opportunistic infections and tumors. But we do have a more contemporary definition that shows us that actually HIV is an inflammatory systemic disease which accelerates the aging process. There is a word for that, that's inflammaging, which is the inflammation that contributes to the aging process. It's not just a feature of HIV, it's a feature of other chronic diseases, such as diabetes, hypertension, renal failure, rheumatoid arthritis. So all those diseases will cause some microinflammation, and it's going to increase the aging process. This is how we age. We are going through this process right now. The calcium is going out of the bones. The calcium is going inside of the arteries. The brain is atrophiating, and we are going to have cognitive disorders. We are going to lose some performance of the liver and the kidney. Our hormones are going to wear out. And also we have the aging process in the immune system. And so that we are more prone to have cancer. We are all producing cancer cells all the time, but the immune system are doing a good job just eliminating those cancer cells. As the immune system age, we lose that ability, and that's why we have cancer, most of the cancers in advanced age. So HIV just accelerates all this process because of its inflammation. Just to summarize that, this is what happened with HIV. We are exposed to a number of strains. We need to be exposed to a very high titer of HIV to have infections. It's proportional, the number of the virus and the odds to be infected. But the infection starts in a clonal fashion. It's like that. We have the dendritic cells that are going to capture only one virus in the mucosal, intravascular, or anywhere. And they are going to bring this strain to the regional lymph node. And then you are formally infected. This takes between 5 and 14 days. Knowing that, it's very important for prevention and using drugs as prevention. Then we have a burst of viremia, and the viremia is going to the lymphoid tissues. And the larger lymphoid tissues that we have is in the intestinal tract. almost 60% of our lymphoid tissue is in the intestinal tract, and just to defend us from all the pathogens that are related to the food. It's our contact with the external environment. And what happened is that we have a massive depletion of the lymphocytes in the intestinal tract. Then we can see that if you are not infected, you have the enterocytes and lymphocytes in between enterocytes. And when you are infected, this number of lymphocytes are going to decrease. And then we start a mechanism that's called translocation, meaning that bacteria is going to invade this space. And as we have that translocation process, we start to detect LPS, that's a piece of bacteria, or CD14, soluble CD14 in the blood. So there is a relationship between the LPS in plasma, translocation, and the HIV progression. And all these LPS are going to cause inflammation. It's the main cause of inflammation. And we can measure the specific inflammation of HIV by the cell activation that we can measure by counting the CD38 and the HLA-DR in CD8 or in CD4. It's more important in the CD8. So this is the specific HIV inflammation, and it relates to the LPS levels. And the inflammation is key in developing AIDS. So why we develop AIDS? Because we are not adapted to this virus. And the adaptation is important for the disease progression. So we have important clue from nature and the SIV model. So this is a sweet manga bee, which is the natural host for SIV, but SIV also infects the rhesus macaque, which is incidental host for SIV. And everything is the same. They have very high viral loads in both. The depletion of CD4 is the same in both, but the natural host is not going to die from AIDS. And the only difference for that is the inflammation, which we call immune activation. So when you have a great immune activation, a massive immune activation, you are not going to replace all the CD4 cells in a good fashion. And good news, we can decrease the immune activation with treatment. This is the level of immune activation in CD8 positive T cells from untreated HIV-infected people. When you treat them and the viral load goes below detection, we decrease the immune activation. Bad news, this is not going to be the same as uninfected people, because even with treatment, HIV-infected people are producing proteins. That's why Western blot will be always positive, and those proteins may relate to the inflammation. And also, you know that besides translocation, the virus itself is going to cause inflammation. So there is a relationship between the viral load and the cell activation. So those are the lead controllers, individuals that are HIV infected, and with no treatment, the viral load is below detection, and the CD4 T cells are stable, are not going to decrease. 1 to 3% of the population that are infected with HIV. So the cell activation is lower than those individuals that have low viral load. It's also lower than those that have high viral load. Those are all untreated people, showing that also the antigenic process may increase the inflammation. So one of the goals that we have for HIV is to mitigate residual inflammation. And what I want to show to you is that STI augments HIV inflammation. Mainly the systemic STIs, but all STIs. I have plenty of examples, just bringing one here. That are the chronic infection by herpes simplex 2. So those are HIV positive people, if they do not have serology for herpes simplex, they will have lower cell activation in CD4 and CD8 as compared to those HIV infected people that are chronic infected with herpes simplex 2. There are a number of trials today that are treating people with herpes simplex, and with this treatment, they can decrease the cell inflammation and also increase the CD4 counts, just giving them drugs for the herpes simplex. And also, I want to show you that STI increase HIV transmission. There is a very nice history that's kind of old, that was in Malawi. Susan Fiskus showed Malawi that the viral load in blood plasma of patients is the same as the viral load in the seminal plasma. But a number of patients in Malawi will have a viral load in the seminal plasma that was higher than in the blood plasma. And they decide to treat everybody with doxycycline for STIs. And then, look what happened. Those are the individuals that didn't have any infection, that were mainly gonorrhea and chlamydia. So they didn't change the levels, or the viral load levels in seminal plasma, that were already the same as in the blood plasma. But when they have Neisseria or chlamydia, the levels of the viral load in seminal plasma are going to decrease and become the same as in the blood plasma, showing that theoretically, those people could be more transmit more frequently HIV just because they have inflammation in the genital tract. And also, HIV does something that's not good for STIs. There is an increase in the pathogenic features of any STIs. I'm going to show some data in HPV, HCV, and HBV. This is some HPV data. So if you get men that have sex with men and you search for anal HPV, we can see that the prevalence is very high. And also the prevalence of high-risk HPV is high, and the odds to progress to cancer is higher as compared with MSM that are not HIV infected. So those are the numbers. Anal cancer rate in MSM with HIV is 78 for 100,000 as compared to 5 to 100,000. So showing that HIV is increasing the pathogenicity of HPV. This is the rate that MSM with HIV, 1 in 600 are going to develop cancer, and HIV negative is 1 in 400, this in 4,000. This can be even higher in some place, such as Australia. And these are the women with HPV. So it's very high, the prevalence of HPV among women with HIV in US, not as high in Thailand. But anyway, the progression of the disease is much faster in women with HIV than without HIV. We can also show that in US, the women that are co-infected with HPV and HIV has a very high prevalence of HPV, anal HPV, and they also have a very fast progression to anal cancer. So we need to be aware. These are our local data, Brazilian data. So what we can see is 20% of a number of HIV positive women are infected with high-risk HPV. Those HPV infected women with HIV, more than 50% will have high-risk HPV. And also 16% of those people, those women with HPV of high risk will have multiple infections, which we know is going to contribute to the odds to be developing any kind of cancer. And talking about HCV now. HCV is a sexually transmitted disease as well. So this is a meta-analysis showing that over time, the chance of sexually transmitted HCV among MSM is increasing. And this is always related to the kind of sex that they are taking. What about the disease progression? If you are co-infected with HIV, the odds of having a liver failure are great. It's 1 time more likely to develop liver failure if you have HCV and HIV, even if you treat HIV, even if the viral load is below detection. The same applies to HBV. So this is the chance of dying for any liver-related disease. If you have only HIV, the odds are low. If you have the HBV infection, but you are not co-infected with HIV, it's still low. But if you put both together, you are going to have a very bad outcome. This is because when you look in vitro, the cells that are co-infected with HIV are producing more HBsAg. So those are the normal cells, and those are the cells that are co-infected. The HIV itself in the cell is going to increment the number of particles of HBV in vitro. Now talking about HIV prevention and STIs, as I told you, prevention is one of the main goals. If you have to mitigate the epidemic, we need to talk about prevention. One of the good things about prevention is the treatment as prevention. So when we treat people, we decrease the populational viral load, and then we are going to have less transmission. This was first done in British Columbia by Julio Montaner. They decided to implement something that's the strategy named test and treat. So if you test everybody in a given place and you treat everybody, you are not going to have transmission events. Then you can eradicate the infection in that place. So they decide to do this in Montreal. They start to test everybody and treat many people. So they increment the number of people being treated, and also they decrease the number of new infections. So the hypothesis was we are treating these people, we are decreasing the populational viral load, so they are not going to transmit the virus. But someone told, well, this is not true. Once we know that someone is infected, we are going to interrupt the chain of transmission, because this individual is going to prevent transmission, right? Wrong. Because when they look at the same time, this was implemented in 2004, although the HIV infections were decreasing, STIs were increasing, such as syphilis, chlamydia, and gonorrhea in the same population. So they are not going to prevent anything. They are just going to decrease HIV transmission because they have been treated. And this is the data from the San Francisco Public Department. It's the same thing. As time goes by and you treat HIV infection, you decrease HIV incidence, but you not change behavior, because at the same time, you are increasing syphilis and gonorrhea. The other thing that's very important, and maybe the better accomplishment in HIV prevention so far, is something that's called pre-exposure prophylaxis. So you get someone that's engaged in the high-risk activity for HIV acquisition, and you give them drugs. The same drugs that you use to treat HIV, part of the scheme. So these people are going to do pre-exposure and post-exposure prophylaxis. And this is very effective to prevent new transmissions, but has the side effects as well. And I'm going to show. This is data from San Francisco Public Department as well. They start to implement PrEP, the pre-exposure prophylaxis. This is going to increase. And what happened is, at the same time, the condom use was going to decrease. So it was negative in behavior. And this is the Kaiser data from San Francisco. It's the Kaiser Health insurance program. So they show that when they start to use PrEP, they are going to decrease HIV transmission to 0. We have the biological plausibility to transmit, but this is going to be 0. But nonetheless, you have other infections, STI infections, being transmitted, such as chlamydia, gonorrhea, syphilis, those 3. So when you have this, someone have an idea. We can do prophylaxis also for those 3 infections. Post-exposure prophylaxis. We can use, for instance, doxycycline. That's going to have activity to all those 3, right? Maybe not that right, but sounds like a good idea. It's not treatment, it's prophylaxis. So we are going to give this for a short period of time. Then they have done this in a cohort, that's the hypergay cohort, and people using PrEP on demand. So when they are going to have any sexual intercourse, they take the drugs before sexual intercourse and 2 days after. And 232 patients were recruited to also take doxycycline after the exposure, the sexual exposure. And it was very good, because people that were going to use the prevention, the post-exposure prophylaxis, had a lower incidence of STIs. So they decreased 50% the chance of having any STI, and this was significant. Was very good for syphilis, more than 80%, for chlamydia, 80%, but was not significant to gonorrhea. It should be, but it's not. And it's interesting because last Friday, WHO just released a note saying that, well, we have a problem with gonorrhea. It's resistant, it's being transmitted through oral sex, and may be untreatable. Right now, we treat gonorrhea with 2 drugs, ceftriaxone and azithromycin, even though they are resistant. So now I can understand why it didn't work for gonorrhea and doxycycline, because probably we have resistance. And just to finish, I'm going to talk about microbiome. Microbiome is something that's important. Look at this. We know that PrEP, pre-exposure prophylaxis, work really well, but it doesn't work well for women, and we do not know why. And there is a clue here. Women with HIV may have something that they call dysbiosis. And dysbiosis is, they have a sexually transmitted bacteria that's Gardnerella. And those are the levels of tenofovir, the drug that we use for PrEP. And we can show that the levels of tenofovir in the vaginal fluid or in biopsy is lower if you have Gardnerella. And also, the microbiome is something very interesting, because the bacteria is there, is in us to protect us from the environment. We have 1.5 kilograms of bacteria in the body. And the colonization starts when you are born. They know that if you have C-section delivery, the microbiome is distinct. So there are some places that they are just using gauze with the vaginal fluid of the mother and putting the mouth and nose of the baby that are born from the C-section, just to correct this. Also, there is something that's the formula and normal breastfeeding may impact in microbiome. And lifestyles, antibiotic use is completely anti-ecological. Sexual behaviors, HIV infection. Someone say that if you kiss someone in the mouth, you're going to change your microbiome. So this is just to show when you use ultra-deep sequencing, next-generation sequencing in the feces, you may see that the normal flora is mainly due from Clostridiales. When you have HIV, you decrease this. Okay, so let's treat those people, because those people are untreated, to see if you come back to the normal flora. And you change, but not much. And some of those bacteria are not identified. And they have an impact in disease progression. We're going to show you. But when you treat those people, some bad bacteria that are not present in HIV-infected individuals and are present in untreated people are going to decrease. So some changes you have. So this is another study showing that we have a high proportion of Prevotella in HIV-infected people and low proportion of firmicutes. And there is a difference, and they saw that this Prevotella is related also with disease progression in HIV-infected people. May prevent the increase of CD4 and cause more inflammation. So, and now just to finish the conclusions, HIV is an inflammatory systemic disease which accelerates the aging process. STIs are prevalent among HIV-infected individuals and augments the HIV-related inflammation and the HIV transmission. In spite of antiretroviral treatment, STIs are more virulent among HIV-infected individuals. HIV prevention strategies work, good news, but they're associated with increase in the incidence of STI, bad news, and the lower use of condoms. Screening of STI among HIV-infected individuals is extremely important and sometimes neglected, and we will need to better evaluate microbiome in the future. This is just my crystal ball, but may be true. Thanks for your attention.
All right, transitioning to our last speakers, Dr. Barbara van der Pol. She is Associate Professor within the Division of Infectious Diseases at the University of Alabama, Birmingham in the United States. She is currently President of the American STD Association, and she's a member of or sits on the board of several medical and scientific organizations, as well as the ISSTDR, International Society for Sexually Transmitted Diseases Research Committee that helped plan this World STI Congress. Her research interests focus on laboratory diagnosis as well as the epidemiological and behavioral research in the field of STIs and HIV. Her extensive experience in the development and evaluation of molecular diagnostic assays has made her an international known thought leader in the field. Dr. Brown.
Thank you, Rodney. It is sensitive. Okay, so I am going to shift topics a little bit, but in fact, I'll be able to build on what Dr. Cosini and Dr. Diaz have already spoken about, because I am going to touch a little bit on syphilis diagnostics, and I will also talk about STI diagnostics, of course, chlamydia, gonorrhea, and trichomonas. So we'll kind of cover a lot of things that are related to trying to find ways to help them get to where they said that they think the field needs to be. I do have a list of disclosures. These are companies with whom I do research and or for whom I speak. And I've organized my talk today in three really broad areas, which include what's new with STI diagnostics, what's coming up in the near future, and what do we need to be thinking about in order to prepare ourselves to effectively work in the near future. So let's start with some of the advances in STI diagnostics. First of all, before we go too far into particularly molecular diagnostics, which is where most of the focus is these days, I do want to reemphasize that culture still has a very important role, particularly for organisms that we think have high rates of resistance, and this would include Neisseria gonorrhea as well as Mycoplasma genitalium. So not only does culture identify active infections instead of just telling us that nucleic acids are present, but it also provides isolates that allow us to do sensitivity testing and see if the drug regimens that we have are still effective. Of course, the problems with culture include very difficult specimen transport conditions with cold chain requirements or requirements to maintain a CO2 environment, time to results, and difficulty in growing these organisms. There have been culture improvements over the last decade or more, and these include things like reporter molecules and biomarkers that can actually be in the media so that you can detect growing organisms much more quickly than we could in the past. Further, there are newer technologies such as MALDI-TOF, et cetera, that will help us identify active antimicrobial resistance. So some of that can be looking for metabolites, and some of it can be looking for genetic markers if we have PCR or other technologies that are looking for resistance genes. And finally, of course, there's next-gen sequencing that we can either use directly from patient samples or we can use from cultured product, again, to try and understand if there are problems or concerns about antimicrobial resistance. And from there, I think, again, an older technology, but I think still worth keeping in mind, and there have been advances in this area as well, are antigen and antibody tests. You know these tests, you've used these tests. Most of them are lateral flow type tests, and they can shorten the window between infection and being able to identify the actual infection in a patient. They may be rapid and simple to use, not all are, and they are often suitable for point of care testing. These are also really useful tests if we're looking at antibodies to understand population epidemiology. And so you'll find a lot of people who can use these tests to try and help us understand how organisms flow from one population to another. Mostly they're of moderate sensitivity and specificity, so they do have to be used with caution. And I'm going to tell you a little cautionary tale about syphilis. So here is a test that's currently available, and it's used in a lot of places. This is a rapid diagnostic test that is an antibody capture test that can use whole blood, serum, or finger stick. These tests as a whole take anywhere from 10 to 15 minutes, and they're very similar to rapid HIV tests that most of us are familiar with running, particularly in outreach settings. These tests, there are a number of these made by different manufacturers. Some of them target treponemal-specific antibodies. Some of them target treponemal and non-treponemal antibodies in the same cartridge. And some have actually added HIV as well, so you can get one finger stick that gives you multiple results. And I just wanted to mention to you an experience that we've had in the US, and the data that I'm going to present here were described at the STD prevention meeting that occurred last year in Atlanta in the US. And a number of people have started using these rapid syphilis tests to try and target people at risk in the community who might not otherwise be tested. So for example, if a person is coming into an STD clinic, this is probably not an appropriate test for them because they're already coming in seeking full services. However, if you have people that you know you can't reach and you know you can take this in the field with you, then that really offers you the opportunity to expand your reach. And many places are doing this with HIV outreach, as I mentioned earlier. So again, you can really give people very full information about what might be going on with their own body. And STD control programs are using this to really be more proactive with their community-based engagement. However, we had data from 2 different states that was presented at this meeting, and what was really interesting is that in both states where they were using this test for community outreach settings, they were detecting positives, but when they actually did laboratory confirmation, only around half of those positives were reflective of an active syphilis infection. So the point to all this is not that this is a bad test. It's not. These were actually true positives, but most of these people were people who had previously been infected. And since it's a treponemal-specific antibody, those positives will stay their whole lives. So I think the lesson learned from this is what could possibly go wrong? We have a new toy. Let's use it. No, maybe not always. We really need to be careful and think about evaluation before we go too far down the road. So the application intended for this particular diagnostic is not as a universal screening assay, but it's intended specifically for people who've never had a previous infection. So that has to be one of the first questions that someone asks the people they're planning on testing. Further, there are differences between this test and an HIV test. Most HIV tests, if you see any positive band, you consider that as a reactive indicating an infection. However, with this particular test, you had to have a band that was colored red. So if you had a band, but it wasn't red, it was actually not a reactive test. But people are so accustomed to working with the HIV test that this actually required extra training and really teaching people how to do appropriate interpretation of the test. Additionally, the timing of the HIV test and this test were different. So the HIV test that some places were using took 20 minutes, whereas this only took 10 minutes. But if somebody waited to read them both together or rushed the HIV test, then you could have inaccurate results on either end of that spectrum. So we really have to be thoughtful and mindful about how we apply these. Finally, the issue comes up. Before you ever start to implement something like this, you really have to think through, what am I going to do when I get a reactive result? What mechanism is triggered? So do we do a full blood draw? If we could do it, do we have the facilities to do the full blood draw wherever we are? Because it depends. If you're at a health fair and you really don't have any place to do that, maybe that's not practical. Do you treat right where you are? You know, are you going to give somebody a shot of penicillin just to make sure you don't lose that person to follow-up? Again, this could raise real concerns because we could have people that are allergic to penicillins, and we could have people who actually did have a previous infection and for whom injection is not appropriate. So we really have to think through the probabilities and possibilities of what these test results mean so that we can develop algorithms for how to manage those results. So with that about older test technologies, I'll move into nucleic acid amplification test, or NATs, which, as you are all aware, these have been in use for 15 years or more now, and so people are pretty accustomed to having these tests and are pretty familiar with what the advantages are: rapid turnaround time, great limits of detection, transport conditions are relaxed. Some of these are quantitative, and some of these tests actually can look for resistance markers. However, there are some downsides, and we need to be mindful of those as well. We have to think about the clinical relevance of a result. So for example, if you have an amplification test that can detect Candida, well, Candida can be a commensal in almost every woman, right? So we need to know that this is an active infection, not just normal flora. So we have to be careful about how we build those tests, and then of course how we interpret them. The same thing is somewhat true of resistance gene markers. Remember that with amplification, we can amplify a minority population. So we might only have 1 in a million organisms that has that resistance gene marker, but we're going to get a positive result. So we have to try and be mindful about, does that positive result mean that we need to change our treatment regimen, or does it mean that we need to change our follow-up regimen so that we actually get people back in and verify that treatment was effective? And then obviously we have to be cautious about distinguishing between screening and diagnostics, right? So most of these nucleic acid amplification tests are perfectly appropriate for screening in all populations, but not all are. And so we have to be thoughtful about application. As I just mentioned, the syphilis test is a great example of when that makes a difference. And there are instrumentation, reagent, and transportation and time costs. So if you're sending everything to a centralized laboratory for nucleic acid testing, it's expensive and it can be slower than you would like it to be. But here are some of the advances that we've had over the last 5 to 10 years with NAT testing. And the first is new sample types. You've heard this before, and Dr. Diaz mentioned it just a few minutes ago, but extragenital testing is actually critical, particularly for people at high risk because they engage in anal sex. And so for many people, and this is actually male and female, but I'm showing you data here just from men who have sex with men at a local clinic at my work group, where you can see that 23 out of 26 infections for chlamydia were found only in the rectum. So if you were doing urine-based screening, you're going to miss all 23 of those. So quite important to be thoughtful of. There are people, especially people in Australia, that have been working really diligently to analyze pooling so that we can reduce cost by having multiple sample types in one sample collection device. And I think in the future that may be the way that we go. There are 2 projects that are working in the US to get FDA clearance for extragenital specimens. And as Dr. Diaz mentioned, there are already some, or as Dr. Starry mentioned earlier this morning, there are already some that have CE marks. New targets, that's another advance in nucleic acid amplification. So we now have a test that's a molecular test for vaginitis. And this test will give you a yes/no result for BV, which is actually a bioinformatic algorithm based on testing lactobacilli as well as Gardnerella adipobium, Snethia, Prevotella, and so on and so forth. But it will give you a yes/no for BV. It will detect Candida, but it detects it in a quantitative fashion, although it gives you a qualitative result, but it has to be well above a certain cutoff in order to indicate that it is actually an infection, and Trichomonas vaginalis. And that's a fairly easy system to use that also has an open channel that can be adapted to other lab-developed tests. Tests for mycoplasma are coming. Many are available in Europe already, and in the US, several are starting their clinical studies to get FDA clearance. So mycoplasma genitalium will quickly be added to our portfolio of organisms that we can test for, all from the same sample. Another advance is automation. More and more instruments are bigger and have higher throughput, requiring less hands-on time. Not all of them have huge footprints, but the throughput is really critical if you're going to have services performed in a reference laboratory so you can get your samples turned around very quickly and results back out to the patient where they are needed for action. And finally, another advance that is already available is faster and near-patient assays. I've just shown you 3 that are available here. The top one is it's a test that can be done near patient, but it's still a laboratory-based test that detects Trichomonas vaginalis. And most of these tests are 30 to 90 minutes. I've shown you at the bottom 2 tests that are available that can detect chlamydia, and the Cepheid test, which is on your right, can also detect chlamydia, gonorrhea, trichomonas. So these are tests that take a varying amount of time, but they're getting faster, and these are really not dependent on having well-trained and qualified laboratory personnel. And so now I'm going to switch to talk about things that are on the way. And, again, as we talked about earlier in some of the sessions today, amplification and amplification technologies are really less of the focus for what we are doing to develop and push the field forward. But instead, we're looking more at solutions for specimen processing, detection of amplified material, which again helps to speed the process up, automation, such as I just mentioned, miniaturization, which helps these things leave the large laboratory, time to results, again, because sometimes it makes more sense to have a fast result while the patient is nearby, and simplicity, so very easy to use, whether it's for a laboratory worker or a non-laboratory professional. I want to mention here microfluidics. Many people are working on microfluidics, and this ties back into the miniaturization process. Microfluidics can be used, if you think about lateral flow assays, they can be used for detection of antigen or antibody, such as we've always done. They can also be used for detection of amplified product. So here's a way that you can have an amplified system and you get a lateral flow readout, so it's something that can be visually read or read with your phone. So that's a step forward in how we're going to use microfluidics to detect highly sensitive assays. Another thing that's coming on the very, very short horizon is multiple pathogen detection. We already have assays that do chlamydia and gonorrhea, or chlamydia, gonorrhea, and trichomonas, but soon we may have assays that can do even more and do them better. And these are done generally, again, using microfluidics and also then a microchip readout, so you can have multiple readouts in one small instrument. And so these things that I've been talking about just now kind of lead us directly into a discussion about point of care or near patient testing. And I just want to remind you, that the point of care testing and near patient testing may be very different things, and they all have different meanings in different settings. But when we talk about point of care, we really mean something that can be done while a patient waits, so hopefully 30 minutes or less, and hopefully can be done by non-laboratory personnel. Because again, this gets us more out to where people are instead of waiting until people come to us. And this is a really old study. It's almost 20 years old now, but it's still really relevant because this study showed that when you had a point of care test with a sensitivity of only around 63%, and you compare that to a PCR test with a sensitivity around 94%, and in this hypothetical case, they just use a patient prevalence of 8%, what happens is that as the probability of the patients returning for treatment gets lower, the actual utility of the point of care test increases. So in fact, if you have trouble getting your patients back, even if you use a slightly worse test, you may treat more patients. So we have to be really thoughtful of this. The good news is that the point of care tests that are in development now aren't going to have poor sensitivity. And so we're going to have really great options. But before everybody goes out and says, I'm going to shift all of my testing over to point of care testing, we really have to recognize that there are some caveats to that. There are hurdles to commercialization, and that's just a regulatory issue that will have to be overcome. Part of that, though, is that these are tests that are designed to be inexpensive, and the cost of getting regulatory approval can be quite expensive, so people don't think they can recoup that. So there may be some tests that are good tests that may never be available in the US, but will hopefully be available in other settings. I'm sure you're all familiar with the assured criteria that were developed by WHO and Rosanna Peeling's group several years ago, again, probably almost 20. And these were talking about affordable, sensitive, specific, user-friendly, et cetera, tests. And that was sort of the benchmark for what everybody was looking for. But we have to recognize what affordable means to me may not be what affordable means to you. And what user-friendly means to me as a laboratorian may not be what user-friendly means to somebody who is a caseworker going out in the field. So we really have to think about these. There are legal issues. If we're doing point-of-care testing, who's the physician who's responsible for having ordered that test? Because there ultimately has to be some medical oversight. We also have to think about the capacity of on-site personnel. For those of you who work in a clinic, and if you see syphilis RPRs being done, this is an 8-minute test, and usually the turnaround time for the patient to wait is 45 minutes-ish, right? Because it takes a little bit of time to draw the blood, it takes a little bit of time for the blood to sit, a little bit of time for the centrifuge, and then you have 8 spots on a card. Maybe you want to fill all 8, so patient number 1 waits a lot longer than patient number 8. Right? So all these things add up, and the same thing would be true if we have chlamydia gonorrhea point-of-care test as well. So again, we need to be mindful of reality and what are these things really going to do in the setting that you work in. And that goes into the throughput as well. And then finally, are we going to need any confirmation algorithms? If we do accept any lower sensitivity tests because we could treat more people, do we have to confirm any of those positives? Or do we have to confirm the negatives? Right? Do we need to take negative samples and send those into a reference laboratory? And there are concerns that are lab specific because, of course, this is what I do, so it's a lot of what I think about. But where should we set the bar for acceptability? Are we really going to require that these point-of-care tests that cost $2 to $5 perform exactly as well as a large throughput instrument, really highly specific, highly sensitive test? And it really depends on whether we're trying to get them out there or we're trying to reach for perfection. But who decides the answer to that question, and what is the process, and who has input into making those decisions? And then more importantly, and you'll probably hear me say this another 3 or 4 times, who's going to provide quality management? When you get a laboratory result, there's a lot that goes into the background of that result, making sure that it's a really reliable, dependable result. We've run all kinds of internal controls, external controls, we do duplicate and repeat testing. There's lots that goes on. And even simple rapid tests can be run, incorrectly. Just as I mentioned earlier with the syphilis test, with people misinterpreting them because they weren't looking for a red line, they were looking for any line. How are we going to catch that? And patients feel a lot of angst when they get a positive result from these things, so we really want to make sure that we're doing it correctly. A lot of these readers need maintenance, they need calibration. How's that going to happen if they're out in the field, right? When do people have to do QCs? Do they have to run QCs every day? That would be too expensive for most places to deal with. Where are they going to get those quality control materials? So there's lots to think about before we just say this is a great idea and let's just all run with it. Further, there are some unintended consequences of decentralization. So when you take these tests out into the field, and the FDA is already considering allowing some of these tests to be sold over the counter, which adds just another layer of complexity, right? But so when these tests are no longer run by healthcare professionals, how are we going to get surveillance and reporting data? How are we going to ensure that people are treated? How are we going to get partners treated? And if you're a woman in here and you're of a certain age, you will know that if you do a pregnancy test at home and you go into your doctor, the first thing he's going to do is a pregnancy test, right? Because they'll never believe you. They're always going to confirm it. What's going to happen with these? So you go in and you say, I ran a positive chlamydia test yesterday, I need treatment. What's the first thing that's going to happen, right? You're going to get another chlamydia test. Is your insurance going to pay for that? Do you care if it pays? I mean, these are the issues that we just have to be thoughtful of. How are we going to get data from a lateral flow strip that's just a line into an electronic medical record, right? How are we going to get data into the medical record that that person's been treated when we did that at a bar or at a bathhouse at 3 o'clock on Saturday morning? So again, these are things where there's a lot of utility to these, but there's also questions that we really have to ask. A lot of the point of care tests are single analyte, meaning they can only detect one organism, but yet the laboratories can detect multiple organisms. So are we losing out? Again, do we care? Do we want to base that on prevalence in our communities? Just questions we have to think about. And finally, tests might be used really inappropriately. So for example, someone suggested to me, well, it would be great if point of care tests were available over the counter because then you could take the test and know you could have sex without a condom that night. I'm like, no, that's not the message. But so you don't know what people are going to think about once these things are available to them. So we do need to be thoughtful so that we can put appropriate warnings and or training messages associated with these tests. But change is inevitable, of course, and these tests are either here or very close to here, and they're continuing to improve technology to the point where we'll have newer and better and faster ones very, very soon. So we need to think about where are these going to be performed, where do they best fit, who's going to manage the quality, what does this mean for disease surveillance? Remember, surveillance is a part of the way that we get funding. So it's not just whether or not the patient gets treated, but it's being able to have data to turn into our public health agencies to remind them to fund us. Internet test ordering is already available. Many of these are not reputable, so you can send a sample in and never get a result. You can send in a sample and get a wrong result. How are you getting treated after that? Are you getting treated after that? You know, a lot of people have angst and worry about something. They'll do a test and then they get over the worry. And so by the time they get the test results back, we have no guarantee people will seek treatment. So we need to really worry about that, and right now there are absolutely no controls on what's offered through the internet. So just to wrap this all up, there are continued advances in our field, and it's a really exciting time to be an STD diagnostician. And I also think it's a really exciting time to be someone who provides case management and healthcare in the field through community-based organizations, because we can offer our clientele so much more than we ever could. And there are options out there that do provide immediate results, and that might result in immediate treatment, but we really need to be mindful about how we deal with those. And I think that we need to be asking questions, and so that's my final thought here, is we need to be ready for the revolution by thinking about it in advance, by talking to our colleagues, by trying to ask companies for what we need so that they're designing what we want to use. And I think that's one of the reasons it's really great when Roche hosts things like this, because it's your opportunity to actually tell them exactly what you want. And so with that, I'll take any questions you have and share questions with the rest of the panel.
Thank you, speakers, for this great series of presentations. We have a few minutes for questions, so there are microphones in between the aisles if you'd like to come up and ask a question, and please address who you are and address who the question is for. Well, I think I'll take a first stab. Dr. Cusini, related to those rapid point-of-care tests for syphilis, I guess, we've seen what's on the horizon. How do you foresee it may fit in within an algorithm, if there will be an algorithm?
As Dr. Van der Poel pointed out, I think it's a very difficult issue to do with rapid point-of-care test for syphilis. You know, I work in a sexually transmitted disease clinic, so it's a particular setting with a particular population. And the problem is, which test do you use? How can you explain it is a treponemal test, non-treponemal test? What is the significance of the test? It's not just the question of testing. If you think that you can order it on the internet, then it becomes really, really difficult. But I know Dr. Van der Poel is right. They are coming, so we have to face with them. And I wonder how many patients will come the next morning asking, and so don't know, really I don't know.
Hello. Yeah, there. Sorry. My question, I'm Manuel Hinabe. I come from the Philippines. I'm a laboratory owner, a clinic owner as well. In fact, we have Roche coming in, very expensive machines. Though my question is directly to Dr. Vanderpoel. In the Philippines, we're a very poor country. So not a lot of people would have access to diagnostic facilities such as the ones like ours, because ours is a little more expensive because we use the more expensive and better machines. So if we have access to China-made strips or rapid tests, just for us to be able to catch the patient and to be able to, give them treatment, would you recommend that we use that if they cannot afford a laboratory setting?
That there are a number of settings where that makes a lot of sense, right? And cost is always going to be a factor. And I think the most important thing to do is to start trying out what you want to use before you roll it all the way out. Understand and maybe do some free testing in certain communities so that you understand what your expected prevalence is. And then if you go in there with a point of care test and you see something that's radically different, that's a warning sign to you that, maybe we need some additional training or whatever it may be. But I think that ultimately the point of care tests are going to be used for exactly that purpose, reaching people that we are not reaching right now. I don't think they should replace our laboratory technologies that we currently use that are really good and really reliable, but I think that they should be an adjunct, right?
Any other questions?
I have one. I'd like to ask, as a clinician, what you think the best ways are for clinical staff to stay up to date on all of the tests that have been approved and are currently being used, either in their own laboratories or by affiliated organizations who might be sending their patients to your clinic, or over the counter.
So the laboratory part is easy. All you have to do is ask, and the laboratory will tell you. And they will either send you over a document that says this is the menu of tests we offer, or even better, you can invite them over and they will speak to your staff and go over the strengths and weaknesses and why they've made the decisions they've made. Knowing what other facilities and agencies are doing that might funnel patients into you is obviously a little bit harder because they may not know. And so, for example, if you were working with an OB-GYN clinic that then sent their patients over to the STI clinic, if the OB-GYN clinic doesn't know what tests they're accessing, then it will be hard for you to find that out. But keeping up with the current, what's on the market and how they compare and how they perform is fairly difficult. There's no one easy way to get at that. I mean, that is one of the things that these types of meetings are intended to fill that gap. The other thing is I think that the CDC's website often tells you some of that information and it can be useful. So right now I would say that for the nucleic acid-based tests that are run in the laboratory, few have significant differences, if any. And so I think that the choice of what the laboratory is using should be able to give you confidence no matter what clinic setting you're working in. When it comes to the point of care tests and as they start mushrooming on the market, which I believe they will, that's going to be a little bit harder and require a little bit of research.
All right, we have time for maybe one more question.
I have one question. Dr. Diaz, in terms of Latin America and what you've seen in the HIV population, I'm just curious, is there a mechanism in terms of screening the patients in Latin America for CTNG, and what are the barriers, and is there a routine screening program that you're seeing now with your patients?
Okay. No, this has been pretty much neglected. There are few guidelines for routine screening of those people, but we need before that to start to screen for HIV itself, and then do the rest. So Brazil has something that's very good. That's the auto HIV test that's being delivered in the pharmacy. So any patient can buy this in the pharmacy as of as the beginning of this month. And so that when they get the test, they need to, it's positive, they have a 24 hours hotline just to tell them how to confirm this. Once they are referred and confirmed, they have all those protocols for STI, which is pretty much in the guidelines. But I can tell you that this is, I just received one message from a colleague right now saying that, well, in São Paulo we run out of penicillin for syphilis, being delivered for pregnant women. That's because the penicillin is so cheap that the pharma companies are not willing to produce this. So we have several barriers in developing countries related to STIs.
It's true in the U.S.
All right, well, thank you, speakers, for a great series of presentations, and thank you, audience, for attending, and please enjoy the rest of the Congress.